Right. So one of the most important fractures here because of the high incidence of fascial growth disturbance, as Alric has pointed out. Second, it's frequently missed, especially with polytrauma, and you may confuse it with ligamentous injury. A little bit about the anatomy. It develops from a single ossific nucleus. It's the first to ossify and last to fuse. Contributes 70% of growth of femur and 37% of the extremity. And what you should remember is if there is damage, you're going to lose a centimeter a year, practically. Right? These are the mechanisms of injury. The classification is usually the Salter-Harris. It helps you in giving a guideline to treatment. By age, it could be put into an infantile group, a juvenile group, and an adolescent group. It's important to know this because if there is a growth disturbance, that is the number of years you're going to end up with shortening. The classification can also be on displacement, whether it's medial or lateral, or it's anterior, so that it helps you reduce the fracture depending on the direction of the displacement. So that is the Salter-Harris classification. Everybody is familiar with it. 1, 2, 3, 4, and 5. Salter 1 is usually a newborn injury, usually seen at birth. It's an undisplaced separation. Sometimes you see it later as a retrospective diagnosis. Rarely you will see it in adolescence, where that is the weakest area when there is a rapid acceleration of growth. The Salter 2 is a small metaphyseal fragment, and displacement usually happens on the side of the metaphyseal fragment. So the direction of displacement usually goes with the metaphyseal fragment. 3 is a partial separation going down into the articular cartilage. So this is an intra-articular fracture, and sometimes a stress X-ray may be needed or additional imaging to diagnose it, like a skyline view of the patella. Salter 4, 5, and 6 are uncommon, sometimes missed with collateral injuries, and there may be peripheral growth arrest and deformation. Clinically, you know all these signs. Look for the hemarthrosis. You could take stress views if you're in doubt, but do them gently. Arthrograms may help, and CT MRI may be used if there is an suspicion about ligamentous injury or later on to look for growth arrest. It is important to achieve a perfect reduction to minimize deformity and growth arrest. If it is intra-articular, you need to get a perfect articular alignment and ensure a good quadriceps function. Undisplaced fractures can be treated just by aspiration and splintage or a cast in about 15 degrees of flexion. The intact periosteal hinge is tightened with these maneuvers. X-rays at 1 week to ensure it's not displaced, and by 4 weeks it usually heals up, and followed by physiotherapy. Displaced fracture require close reduction. Don't do it without anesthesia. Joint aspiration always helps because it decompresses the joint. The first maneuver has to actually increase the deformity. So most of your maneuvering has to be traction to avoid damage to growth plate rather than shearing and pushing it. So pull it, increase the deformity, and then tilt it over to close the gap. Examples, displacement anteriorly. Think of this as a supracondylar fracture of the humerus. You can put the child in the prone position and do the maneuver like you reduce it with, for supracondylar, and then you use cross pins. The pin should be removed early because they are crossing the physes. They gum up in 3 weeks, and then you rehabilitate. That is after wire removal. But always make sure you follow them up for the Harris growth arrest lines because, as I said, growth disturbance is the most common complication. Salter-Harris type 1 again here. Sometimes you can have a growth arrest because periosteum can get entrapped here, and rarely you would need an MRI and surgery to get that entrapped periosteum out from that area. When you're using pins, make sure you're avoiding the perichondrial ring. When you're using screws, go from metaphysis to metaphysis, avoid crossing the physis. Examples, you can see a large metaphyseal Salter-Harris 2 here, and you can stabilize it with a screw like this and then cast it. Wherever you are crossing the epiphyseal plate, use a smooth pin and make sure that you remove it early. So screw has to be from metaphysis to metaphysis, and a pin can grow across the epiphysis, but make sure you remove it quite early so that it does not cause any damage to the growth plate. 3 and 4 will need open reduction, and as I said, the screws have to be parallel, minimal fixation, and early mobilization. Sometimes you get combination like this. You can use arthrography to get a percutaneous closed intra-articular alignment, and then you could use a plate or multiple K-wires and a cast, something like this. if you use a plate, make sure again that you are going to be away from the growth plate and remove it early. Severely comminuted fractures like these with patellar fracture, you must reconstruct all the articular alignment. You are going to get a growth arrest, but you should be sure that you are going to get that articular congruity which takes precedence over the fascial injury. And that is how this healed. He had a stiffness, and post arthrolysis we could give him full range of motion. So I'll stop here. Thank you very much.